All right, folks, we're going to get started. Good morning, bright and early, slightly rainy morning here in Philadelphia. Hopefully, everybody got to enjoy the nice weather yesterday. My name is Mike Jones. I'm the Vice Chair of Emergency Medicine at Jacobi and Montefiore in the Bronx. I'm also the co-chair of the Trauma Interest Group. And I'd like to welcome you to our session this morning, our advanced workshop titled Innovations in Trauma Resuscitation and Management. This is sort of a brainchild of a collective group of us from the Trauma Interest Group, something that we try to put on a every other year basis, so a sort of panel discussion and looking at some of the latest and greatest innovations in trauma care. Just quickly, we have generally no financial disclosures. Dr. Johnson is going to give his own financial disclosures prior to his discussion. My co-moderators and organizers, Dr. Kaushal Shah, Dr. Robert Flintz, will be talking to you in a minute. And we have experts from all over the country in a variety of topics, and they're going to introduce themselves as we get to each of our topics. And like I said, Dr. Johnson has his disclosures. Learning objectives. I'm going to pass that along to Dr. Flint.
Hey, good morning, everyone. Thanks for joining us today. Yeah, you're going to be really impressed getting up. Oh, I'm sorry, I'm standing right in front of it. You're going to be really impressed. I saw the slide deck last night. You're going to really learn a ton this morning. So we're going to kind of overall talk about understanding best practice in video resuscitation and kind of look at some scripted resuscitation management. We're going to look at novel hemorrhage control agents, which is a really interesting topic and kind of on the edge there. We're going to talk about REBOA, which is a very polarizing topic, so we'll see if we have any pro or con REBOA people here in the house today. And then we're going to a really nice talk about institutional responses to violence mitigation, which obviously impacts each and every one of us here in emergency medicine. So buckle up. It's going to be a good 2 hours, I think. I'm going to hand it off, give a little history of the organization here.
Hi, everyone. I'm Kaushal Shah. I'm the Vice Chair of Education for Cornell in New York City. And I'm going to talk a little bit about the Trauma Interest Group and a little plug for it. I guess I started with my interest in trauma when I was a resident in like literally early 2000s. And at the time, trauma was really exciting because there was a lot of action, but it was very simple. It was algorithmic, and that's why I sort of got into it. I liked the simplicity of it. And then over the years, it got more complicated. We've gotten a lot of research done in trauma. We have the one-to-one-to-one. We do like the REBOA stuff. There's hemorrhage control. It's been growing as a field of science. And so over the years, the Trauma Interest Group has had sessions like this. We had even a half-day symposium. We've done like a 1 hour, it was an hour and a half maybe session a couple of years ago. And then this year, we kind of floated the idea of maybe doing a 2-hour advanced workshop. And that's what we've kind of put together for you guys today. And hopefully, I mean, this is a broad range of topics, even within trauma. So I hope you guys enjoy it, and if you guys aren't part of the Trauma Interest Group, do sign up. We have a session where we get together, and sometimes we talk about interesting abstracts at the SAEM and ACEP meetings, so please join us in the Trauma Interest Group. But then I think we're going to get started.
Great, thank you, Kaushal. Our agenda for the day, just for the morning, we covered the introduction already. We're going to talk about video review for trauma resuscitation, novel adjuncts in hemorrhage control, REBOA in trauma, violence mitigation programs. And then we'll have an opportunity for a moderated panel and audience questions. So we really do invite participation. All right, so that's my cue to introduce our next group, Dr. Williams from our Medical College in Wisconsin, and I'll let you guys introduce your whole team. Thank you.
Sounds great. All right. So good morning, everybody. My name is Kathleen Williams. I'm an assistant professor at the Medical College of Wisconsin, where I also serve as the residency program director, and I will let everybody else up here introduce themselves now.
I'm Seher Khan. I'm an assistant professor at the Medical College of Wisconsin. Actually went to med school there and trained there under these two, and now I get to work with them as colleagues, which is pretty cool. I'm in charge of the kind of trauma education curriculum for both our EM residents as well as our trauma residents that we do together. And then we all serve on the committee for video review, but I'm the one that's always there because I have nothing better to do with my time. So yeah, we're going to chat with you guys today about video review.
Good morning. Thanks for having us. My name is Matt Chin. I'm associate professor in emergency medicine at the Medical College of Wisconsin with these lovely people as well. I work as the senior medical director for our emergency department, Frater Hospital. So our system is a level 1 trauma center in Milwaukee, Wisconsin. We see a volume of about 80,000 patients a year. We have roughly 4,500 trauma patients and about 2,500 trauma activations a year. So we do quite a bit of work in this area and have a good relationship with our trauma team, and we're really privileged here to speak to you all on this trauma video review resuscitation.
All right, so we'll get started. So our little section learning objectives. So our goal this morning is to review some of the history behind videotaped resuscitation for trauma. We're going to highlight some of the policy changes that are required if you're interested in getting involved in a program like this. Describe the committee makeup and some of the technology that we've used at our institution over the past several years. And then at the end, we're going to demonstrate some uses of this program for things like education and some novel scholarship around operations as well, and then physician coaching in addition. Yes? Yeah, that's a great idea. Raise your hand if you have a trauma videotape resuscitation program at your institution. Okay. So only a couple, yeah. Yes. So we're going to talk about that too, why everybody used to and doesn't anymore. So let's first talk through some of the history because I think it's really important and relevant to the topic that you just brought up. And it's really been an up and down history over the past 60 or so years that we know that this type of videotaped resuscitation has been in existence. Oop. Ooh, that was weird. All right. So there's actually the first literature that came out about videotaped resuscitation for trauma came out actually as far back as the 1960s. There were 2 papers actually back then, but really was in the surgical literature, really focusing on operative management of traumatically injured patients and around physician coaching for operative cases, very procedurally based. In the 1990s, we know that there was an increase in these types of programs. We think to around maybe about 30% of trauma centers at that point had videotape resuscitation programs. And there was some increasing literature that came out of the late 1980s and early 1990s around this topic, particularly focusing on, hey, this would be really great for things like education coaching. It really leads to prolonged learning and improved outcomes for patients as well. And then in 1996, the Healthcare Information and Protection Act was enacted by the US government. And despite, this really focused on protecting patient information and does have a pathway where you can still use healthcare information for quality improvement and education. But despite that, there became some fear around using videotaped resuscitation. In the early 2000s, CMS additionally added on this consent required for videotaping in healthcare settings. And so the combination of those 2 things really led to video review falling out of favor. A lot of institution legal teams were like, we're not getting involved in this. This is too risky. And so we think based on those sort of 2 government-related acts that were placed, video review really fell out of favor, and we think that it went from around 30% down to at least as low as 15%, if not lower. And now we're sort of in this period of time where there's sort of this resurgence happening. There's a lot more literature coming out in the last 5 to 10 years, really exemplifying why this is important, really kind of pushing the opportunities for this as a tool. Particularly in education and operations. Ryan Dumas, who's like one of the main folks who's writing about this, he's a surgeon out of UT Southwestern, and actually one of our colleagues at MCW actually put out a paper a couple years ago that said, there's so much literature saying that this is a valuable tool. We think it should be part of the American College of Surgeons trauma accreditation. And so that's a little bit of a controversial topic, but kind of an interesting bold statement that says how valuable this is. So to give you a little background about us, Dr. Chait already mentioned kind of our context, but just to reinforce it again, we're the only level 1 trauma center in all of half of the state of Wisconsin. We see 80,000 visits a year. We have around 4,500 trauma volume a year and about 25% penetrating. So at our institution, just like many others, we had a video review program in the 1990s. In addition to that HIPAA and CMS mandate, we in Wisconsin had our own state law that came out that was specifically around voyeurism, taking images of people in an undressed state, all of that. And so like the combination of the three things that came out, our legal team was like, we're done. We're not doing this at all. Around 2015, when I was an early faculty member, there was conversation starting around, can we restart this program? And so a lot of intense work went in with our legal team to talk about how do we kind of work within the context that we need to. And so we did things like develop specific language that was added to our conditions of admission form and several other things, really with the goal of restarting our program to allow its use at our combined monthly conference that we have with our trauma surgical team. And so I'm going to hand off to Matt to talk a little bit more about some of these policy changes.
Yeah, so like Dr. Williams mentioned, we really had to take a multidisciplinary approach. We worked with our risk and compliance teams, our legal teams at the hospital, as well as our trauma and emergency medicine programs to really understand kind of what scope we could apply to this. And this is kind of what we come up. I know it's a little bit small. Really, we tried to take as broad of an approach as they'd allow us to have so that we could encompass trauma resuscitations. We also built in some language to expand this to medical resuscitations, which we've kind of looked at building a program around as well too. And then our trauma program actually wanted to extend this through the operating room so we could get kind of the full scope of that. So our current policy looks at all the way from arrival into our resuscitation bays and that kind of debrief all the way through the operating rooms and allows us to see that entire continuum of care. And that policy really supports us to do that. And it was kind of an approach we took after discussion with all of those teams to make sure that we were compliant with state laws as well as compliance with HIPAA. So when we, again, this is a really small version of it, but really there's a couple key factors to look into here. We have some very specific, guidelines that say what we can and can't record and what we will and won't do with the data that we record there. So really we've built a committee and we'll show you kind of what that multidisciplinary committee looks like on a few slides here, but really restricted access to people that are on that committee. We have kind of a password protected, cloud-based recording system that only allows access to a limited number of people. So we're very specific about who we designate to be able to access the data there. We, again, have very strict timelines on how long we can actually keep the data. So we have a 45-day timeline where that data is automatically deleted from our system. So we've built it into our software where it actually removes those videos after 45 days. So we don't have to actually think about it. That video is just removed after 45 days. We also look at kind of the review sessions for the recording. So those are limited to a specific set of people who are members of this committee. And then we have specific flags for things that we record. So those are what you see here. So flags for performance improvement opportunities, again, specific, but also a little bit vague, allows us to really include things that we find pertinent to both education or coaching or potentially specific topics if we're looking at procedures, trying to evaluate that or performance of those. We look at obviously all of our trauma activations. Again, like I mentioned, we have a medical resuscitation video review program as well. So we've built that into this policy. So not only is it just trauma video review resuscitation, but this policy just encompasses all the things that happen in our resuscitation bay. And so we've included the medical part as well too. Since many of you know, obviously medical resuscitations are a huge part of what happens in resuscitation bays. And then obviously this includes our trauma operative cases as well. So our trauma operating room has the same cloud-based system with video recording in it as well. So they can actually review the operative interventions that happen all the way from kind of pre-op setup all the way through the end of the case. So like I mentioned, really the important thing to think of when you're considering how you develop these programs really is who's going to be a part of your committee and how do you get the most value of it. You don't want to make it too large, but you want to make sure you have the right people. So this is just an example of what ours looks like. So our trauma program manager kind of really leads the kind of operational level things of acquiring the videos, kind of making sure those benchmarks are pulled, pulling the case numbers so we can find them. We have frontline staff. So from our nursing staff. We have frontline nurses, we have frontline physicians as well, from both the trauma team as well as the emergency department team. And the reason we have that is because you're all looking for different things, right? So your trauma surgeons may be looking for something specific to theirs. Our emergency physicians are looking at the airway management, for instance, or they're looking at procedures done by their residents, or in trauma may be looking at procedures done by their residents. We alternate our captains as well on a weekly basis. So obviously both of those groups are evaluating what that communication style and what that performance looks like from the captain in terms of communication. We have those surgeons you see there. We have our nursing leadership team as well. So really important to really cascade the messages. And, we talked about some of those things being education and coaching opportunities. So we have our nursing leadership team there as well to help cascade those messages to all of our frontline nurses who aren't in this meeting. And so I think they provide a really valuable feedback mechanism for us to a broad base of people who are involved in our resuscitations. They also help with feedback to our paramedics. So we use techs and paramedics in the emergency department for these resuscitations as well. So they're able to provide that feedback, whether it's communication or, I'm sure many people have had issues with their level 1 or their Belmont infusers. So we've done a lot of troubleshooting with that, and they're able to kind of look at the issues that have come up with utilizing those machines in our emergency department. We use the Belmont, and so we had an opportunity to do some quality improvement around that as well. And then we actually have our CNS as well, to our clinical nurse specialist, who again helps with that messaging and cascading down that education to those people. This is the technology that we're using. So we made an upgrade in our technology. We used to use kind of a local password protected server there, but we've actually transitioned, and we'll show on a subsequent slide here kind of what our software looks like. But we've transitioned to really a cloud-based recording system. And so it involves 2 cameras that are placed in our emergency department, one towards the head of the bed, looking at the airway, one towards the rear of the bed, following the captain, as well as it gets an overall view of the resuscitation in general. We use artificial intelligence technology, so our system is actually able to scrub faces from a privacy perspective. So when we actually review the videos, it actually will automatically scrub the faces and blur them out. It can modify voices as well too, to help with confidentiality and stuff around that. So that technology also does 24/7 recording. So it records 24/7, but again, uses AI to get rid of data when it realizes nobody's in the resuscitation bay. So it's really helped us improve our recording capabilities. So it notices when, for instance, a pre-debrief might start before a patient even arrives, all the way through to that patient's disposition, and then it deletes all the data when that bay is empty. So it's really been helpful for us to really capture that entire continuum of care. To assure compliance, we've actually posted signs throughout our emergency department mentioning that we're using video recordings. Our resuscitation bay has signs posted as you enter our emergency department, and throughout the department it has signs posted that you may be video recorded for quality improvement activities. So that was part of the compliance requests that our legal teams made, and so we've made that accommodation throughout our emergency department. And again, we've really found benefit to the cloud-based storage as well. We used to, again, have a local server that would store this, so you'd have to actually manually retrieve it with a flash drive that was password protected. But now actually with username and logins, you can actually access this from anywhere. So we do a lot of pre-screening of our videos by some of the committee leads there to make sure that to look at a larger volume of videos, and then we bring the ones to the committee that kind of meet those performance criteria that we're trying to evaluate from a committee perspective. So it allows people to do that asynchronously from wherever they are. So it's really been great for us as we made that transition over the past year or so. So this is what it looks like. So this is the rear camera kind of towards where the captain stands and us. You can see it really gets a good view of pretty much everything in our resuscitation bay. You can kind of see what our bay looks like. You can judge us or not. But this is kind of our general resuscitation bay setups. On the left, we have a sea locker with all of our procedural supplies, so we can see people retrieving those. We have our Belmont infuser usually on the left as well, so we can watch troubleshooting occur if that machine has some issues. We have our airway set up in the front. We have our kind of IV carts on both sides there, and then it gives us a good view of kind of all the people that are involved in resuscitations. It's a really great program in that we can actually flip these views. So again, I said we had another camera at the head of the bed, so we can actually watch the airway doc as they're doing their airway interventions there by flipping the camera to the other one. And it actually has the ability to hook into your any of your equipment that has audio or video outputs. And so we use a store CMAC, so we can actually plug that into the tower there. And so we can add a third view of the CMAC specifically. So we leave our CMAC plugged in. We have one assigned to each resuscitation bay. It stays plugged into the system. And so when an airway is performed, we can actually toggle between those 3 camera views and see what the airway resuscitation looks like. And we can watch the entire airway management procedure done by the emergency medicine resident, usually faculty. So that's been really helpful for us. It also live streams all of our telemetry data streaming on the left there. So you can see we could cycle through there. Anything that shows up on our head units there will show up in there in real time. So we can trend, resuscitation markers. We can look at blood pressure and heart rate. We can trend kind of all those things. It'll plug into the A-lines and capnography, and everything that will show up on your monitor will show up in a duplicate version on that left side there. That's been kind of a key improvement for us over the last system, is really to have that live streaming data. On the previous system, you really had to squint and see if you could see on the monitor there what it was showing. In this display, actually, you get the live streaming data in real time. The bottom is basically a timeline, so you can fast forward, double speed, you can skip ahead. And again, the AI technology really starts the video at whenever somebody shows up in the bay, and that could be our staff doing a debrief all the way through the end when that patient's dispositioned. And so you can kind of fast forward through that entire thing. And again, we use those time benchmarks at the bottom as well to do some quality improvement activities related to that. So I'm going to switch it over to Dr. Khan for some educational stuff.
Thanks. All right. So like Matt and Kathleen have mentioned, one, there's a lot of history with video review in general, but specifically at our institution, there are a lot of operational and QI reasons to do video review, but there's also a lot of educational opportunities with video review. So we, like I mentioned earlier, do a monthly multidisciplinary conference between us and our trauma surgery colleagues. So any of the surgery residents that are on their trauma rotation, plus all of our EM residents, on the second Thursday of every month, get together at 7 a.m. and we go over a video case. So the videos that we review on a weekly basis, we pick one out, or I usually pick one out, that has maybe some high yield learning opportunities for our residents. So think about it, not every case that goes through your emergency department, every resident is gonna get to interact with, but with video review, you can actually pull a lot of those learning objectives and clinical teaching pearls from one case and share it with a room of like 50 people, which is great. So again, those like high acuity, low occurrence procedures or patient traumatic injuries, those are all really important things. It's also a great way when we're seeing trends. So like if we're seeing trends that chest tubes are being performed under unsterile conditions, that's a great opportunity to remind our residents and our faculty of like, hey, let's make sure we're being sterile and let's watch this video. And it took us an extra 45 seconds to make sure that we're setting up a sterile procedure for this patient, right? And then it's a great way too to encourage systemic change. So historically, we didn't always do pre-arrival huddles for our trauma activations. It was very captain dependent. So depending on, maybe the EM resident, if they were a second or third year and what their comfort was with resuscitations. If it's a trauma resident, they have different skill levels when it comes to running resuscitations compared to our EM residents. And so sometimes they can be a little bit more on the quieter side. But this was a great way for us to show like, hey, one, this pre-arrival huddle took like 2 minutes. 2, do you see how fast this resuscitation went then? Because everyone had a common goal, right? This patient fell down the stairs. We're concerned about a head injury. My goal is to get them to CT scan. So with the captain setting that tone in that first few minutes before the patient gets there, you can see the entire team knows that our goal is to get to CT scan, right? So there's not that like lag in activity. Everyone is doing the things that they need to do for a shared common goal. The other systemic changes that we've done through this, we actually use this multidisciplinary conference as a way just to get buy-in from a lot of our key stakeholders. So unsurprisingly, patients who are victims of trauma, particularly interpersonal violence, are at very high risk for PTSD. And so what we did was we kind of integrated this standardized assurance of safety that either our airway doc or the right doc discusses with the patient, like, hey, you're at Freighter, you're in a safe place, we're going to take good care of you. And we use conference to get buy-in for that, like to talk about the importance of doing things like that, and to make sure that our patients aren't dealing with a lot of secondary and tertiary injuries as a result of being trauma patients. And that got everyone on the same page. And then again, we can show it in video review, like, hey, look at how quick this was, that Right Doc was able to do this before the patient even transferred over to the cot. Like, it's a great way to get buy-in from your team. The other important part about video review from an educational perspective is targeted feedback, right? So it's one thing, Dr. Williams is our program director. It's one thing if I tell her, hey, this resident might be struggling with this, or hey, this resident's doing a really good job with this. It's another thing when you see it in video review or you see trends again. We also kind of dedicate certain people for that feedback. So Dr. Chin handles a little bit more of our EM faculty feedback. I handle more of our individualized resident feedback. And then the trauma team kind of divvies up their feedback for their team as well. And it's a great way to assess leadership skills. Again, that's something that's can be a little bit intangible, right? I can tell you someone's good at running a trauma or running a resuscitation, but it's hard to always pinpoint why that might be. And so we use a standardized trauma no-tech score, which is valid and reliable in assessing leadership skills in people who are captaining or leading trauma resuscitations. And then lastly, there are a ton of scholarship opportunities. So, I'm an education person. I think it's important to educate the next generation, but working in academics, a part of this too is producing scholarly activity. There is a ton of room for educational scholarship in this realm. From a surgical perspective, they're the ones that are actually doing a lot of the literature and the publications, and a lot of their focus is more on the quality, the QI indicators, as well as some technical skills. There's not a ton of literature out there on how to use video review in an educational perspective. And there's not a ton from the EM side, but I would argue, our institution is such that we alternate captains every week, and so our EM residents are as involved in trauma as our trauma colleagues are, if not more, because we're in the Bay when the trauma comes, and trauma has to come from a different part of the hospital. But there's a great area of opportunity for us to grow in this realm and kind of encourage ongoing education in video review. There are also some operational-based scholarship opportunities. So at our institution, we standardized EMS handoff through a DMIST acronym to make sure that we're getting an efficient, direct communication of everything that happened prior to coming in without having a 2 or 3 minute long EMS handoff when a patient is critically ill. We also use it to monitor PPE compliance. Historically, that's what we did, and to make sure that people are wearing the appropriate PPE for their own safety as well as the patients. And then again, talking about sterile conditions to make sure that we're providing the safest care for our patients.
So from a quality improvement perspective, indications are really the world is your oyster. So it depends what you want to look at your institution and what you find most beneficial. These are some of the key benchmarks that we actually track in our institution. So we're looking at patients that are emergent to the OR. So we're trying to figure out either door to CT or door to OR times for those particular patients. So we're tracking those metrics and seeing opportunities for improvement in how that initial resuscitation worked and how we can make that more transfer to the operating room more efficient. We're looking at all of our MTP activations, one for kind of speed to activation and clarity. So there's some literature on kind of closed loop feedback and what that looks like for ordering blood. Do you want whole blood? Do you want packed cells? Do you want MTP? Do you not want MTP? So we use that to kind of track our communication and then provide feedback on how that blood ordering process went. And then we also use it from an order compliance standpoint because blood ordering is typically a verbal order. So we're trying to figure out how we can do this better and what we can do to integrate actually into Epic, which is our EPCR system, to figure out how we can order blood in the system as well as the verbal orders. So we look at our halo procedures like Dr. Khan mentioned as well. So we're looking at, ED resuscitative thoracotomies. We're kind of reviewing all those types of cases, patients that are getting emergent airway intervention. We're watching those cases as well. We look at any deaths in the emergency department or in a resuscitation bay, understanding if there were opportunities for improvement in those cases as well. And then we actually have provider requests. So we built a QR code actually that's in our emergency department where anybody can scan that and then submit via kind of a HIPAA protected form to our video review team to have a case reviewed for any of the sorted reasons they would like to. As part of that, we specifically have them address what issue they'd like for us to look at so that we have a target to kind of evaluate in that video. But we allow our frontline teams to really send the cases to us for us to look at as well where they think there's potentially opportunities for improvement. Our data collection themes like Dr. Khan mentioned as well for communication, leadership, those intangible things that are really hard to measure on an objective scale, but really helpful to watch a video of somebody doing something really well. Our assessment and diagnostic interventions, skills. So again, we've done some targeted interventions kind of with video review looking at particular skills. So whether that's fast exams, so we had kind of improvement activity looking at increasing our utilization of fast, and then kind of looking at how fast our fast exams were amongst our residents, both between interdisciplinary between the trauma residents and our emergency department residents as well. So with target education and going around that, trauma informed care, like she mentioned as well, pain management, vitals and monitoring. So we've done a lot of work around vitals and monitoring. Surprisingly, what we realized with some of these programs is how long it actually takes to obtain vitals, and then how often sometimes our residents or captains will perseverate on getting a blood pressure, even if it's 30 seconds or a minute or 2 minutes, because the automatic blood pressure continues to cycle. So really focusing on how we're going to move forward in the resuscitation when that happens and what our tactics will be, because we noticed that quite a bit on some of our resuscitations. Airway management obviously is something we look at closely. We're again able to get a really good view of kind of what the actual airway looks like via that CMAC monitor that's again live streaming into this data. And then again, thermal management and MTP, things that we looked at as well. Again, just in conclusion, so we do videotaped resuscitation really allows us to evaluate the entire continuum of care. Like Dr. Khan said, she's been really integral in kind of integrating a pre-arrival huddle with discussing kind of the information that we get from our EMS colleagues ahead of that patient's arrival. So this technology allows us to track that entire discussion so we can watch that pre-arrival happen. We can watch the handoff that she mentioned as well. So that demissed handoff, we are lucky to be very close with our EMS colleagues. The medical direction comes from within our department, so we're able to kind of integrate changes there too, so we can watch an entire EMS handoff happen and occur. And actually, we've provided feedback to EMS on what opportunities exist for that to improve, or when they've done really exceptional jobs with handoff, really given us that exact demiss format, done it 30 seconds or less, and we're able to get that patient transferred over with all the information we need. We look at the any procedures done, obviously the airway interventions, and then we obviously can track relatively closely and in real time. A lot of times we were tracking kind of retrospectively based on when a nurse may document you're going to CT scan, but we can actually now see the exact arrival time, the exact time we left that wheels out of that bay into the CT scanner or to the OR, so we can find all that. And again, we're lucky again to have this technology track through our operating rooms, so the trauma surgeons can actually follow through with the operative interventions on the same patients that we saw arrive all the way from EMS. So that's been really helpful for us. Pass it off to Kathleen.
I just wanted to say, like, the experience that we've had over the past 10 years in redeveloping this program has really involved a lot of conversation with key stakeholders. And so I think if you don't have a program like this right now, it's really important to do the background work and do a lot of the legwork to get those conversations up front with all of the staff that'll be videotaped, all of the administration in the hospital. There's so many people that communication to develop something like this is really important. I think the other thing to take away is despite a lot of the legal concerns that have come up, there's actually no data showing that this has ever been used in an actual legal case. So if you're trying to get a program started and your legal team is nervous about it, I would just share that data and information as well. And really kind of focus on the opportunities. This is a huge tool that can be used in all of your resuscitations. We've seen a really interesting development in the extension of the operating room, and really to see a patient's care all the way from when they hit the door to when they finish their time in the OR. And this is just ripe for scholarship. So my other final argument is, like, surgery's like taking the reins on this, and should be our thing. So let's maybe start writing more and more about this, and this is on us as well. Like, this is a huge area of opportunity for scholarship, so I think we should kind of own it. So, all right, that's all we have to say. So thanks.
Great. Thank you so much. We're going to hold questions for the panel discussion at the end. Thank you.
All right, next up, we're going to do novel adjuncts in hemorrhage control. I'm Dr. Leon from UC Davis, and I'm combined trained in both emergency medicine and anesthesiology. So when I do trauma, I actually sometimes take care of them down the ED. I also sometimes take care of them in the OR and sometimes in the ICU too. So I see kind of the spectrum of care. So some of the things I mentioned here will be either very early into its innovations or not super applicable in the ED yet, but take what I say today with a grain of salt. So going right into it, here are our main objectives here. And identify basically currently available non-pharmacologic adjuncts as well as pharmacologic adjuncts, and then just talk a little about research into novel approaches of way of hemorrhage control. Because as we know, controlling hemorrhage from the time of injury is most crucial to improving mortality, morbidity, and trauma. So getting right into it, there's kind of been a paradigm shift in trauma. A lot of it, with the focus of stop the bleed and stop the pasta water. So basically a focus on CAB, so instead of ABCs, going first on controlling bleeding and doing hemostatic resuscitation rather than giving crystalloid. Rather than giving those 3 liters of crystalloid and then considering giving blood, rather than not putting on tourniquets, just letting long hospital times, getting them to the OR without doing any resuscitation before. Now there's been a kind of a shift to instead focus on trying to control the bleeding as soon as possible, trying to get the blood to the patient as soon as possible, and doing whatever we can to control the bleeding before they can get to DCR, so damage control surgery. So we do damage control resuscitation is a big item. Some of the things that you may have seen come out, especially in the pre-hospital realm, is this acronym MARCH, which is kind of, so here's CCAB, and then this is MARCH, which is basically, again, a focus on instead controlling massive bleeding before dealing with airway, and getting blood to the patient, stopping bleeding before anything else. So again, going through damage control resuscitation, a big push by particularly the trauma surgery world, but now trickling down to most major trauma centers now is, again, focusing on identifying bleeds, identifying massive hemorrhage first, and doing what we can to stop it through hemostatic resuscitation. So minimizing crystalloid, maximizing patients' coagulation, trying to reduce coagulopathy, trying to improve their platelet function, try to keep them from getting acidotic, and giving them blood and giving them the products that they need. And we've seen that this is kind of now gone to the pre-hospital realm with bundled care. A lot of these, you may have seen these packages of ARC, so advanced resuscitation control. So these are basically specialized trauma units that give blood, TXA, and calcium out in the field and put on tourniquets as early as possible. And it's actually showing reduced mortality and morbidity and reduced total blood units given through their entire hospitalization. And so you may see some of your pre-hospital rooms start to adapt these where they're giving blood, they're giving TXA in the field, they're giving calcium in the field. And it's actually showing pretty good results. And surprisingly, it's also showing good results in reducing things such as even pre-hospital intubation and ED intubation. And it's also just showing overall mortality, and importantly, mortality is going down. So with all that being said, what does this mean for trauma? What are kind of the new steps? I think we already know. First step, recognize bleed. Classic trauma, get the patient naked and do a complete assessment, find the bleed. And then the thing that is changing is we're now starting to use a lot of clinical tools. Things, you might have heard ABC score, I've got modified shock index, TASH. Use whatever clinical tool you would like to help provide you the emphasis that this patient needs blood. Kind of a additional component is that now we're starting to see more and more point of care testing. So whether that's rapid tag, whether that's point of care INR, whether that's point of care hemoglobins, these are all things that you want to use early as soon as possible to help guide your resuscitation of these patients. And then once you identify the bleed, of course, you want to stop the bleed. And obviously, stopping the bleed as soon as possible through whatever means you can prior to getting them to the OR or whatever is going to be their main form of surgical intervention that's going to stop the bleed. You want to do what you can through tourniquets, through hemostatic agents, and we're going to go into that about some of those different ways. So classically, to stop the bleed, what we do, we'd grab some gauze, put pressure. Now we're finding more and more tools to give direct pressure into areas. And so a lot of this is now mostly in the military, but now it's making it into the pre-hospital realm. Those things include jet or SAM or croc, which are all these what are junctional tourniquets, which can be placed in junctional bleeds. You also have things like wound closure devices, which are going to be like the IT clamp, and pressure bandages, which are all ways to give direct pressure and try to control bleeding before surgery. So, kind of looking, these are examples of some of the advanced tourniquets here. You see up there the SAM, the jet, the croc, and the AAJT. These are all junctional tourniquets that provide pressurized direct compression onto major bleeds, and this can be used even on in place of REBOA is the thought that they're trying to move for so that it can allow for pre-hospital realm. There's not good data on that yet, so I'm not going to talk more about that. But just know that you'll start seeing more and more pre-hospitals beginning to use these kind of junctional tourniquets for junctional bleeds. And by junctional bleeds, those are ones usually in the groin, in the axilla. And then if you have no tools on hand, you can actually even do a manual aortic compression. There's a new technique that's starting to be disseminated out there, particularly in the military realm, but you can provide direct manual compression into the aorta. So this is for like catastrophic aortic injuries or interperitoneal injuries by placing the knee essentially right over the aorta. It's a very DIY mechanism, but it's another mechanism that is available in times of trying to stop massive hemorrhage. So a few other items here. IT clamp is the only one out there, but we'll just more globally call them wound closure devices. These are great for bleeds that are either on the neck or axilla or other areas that are difficult to put a tourniquet on itself. What you usually want to do with these is you want to pack them, and then it essentially is two edges that can help bring the area of bleeding together and temporize bleeding. And then we have you may have seen these quick clot, Celiox. These are all different versions of gauze. Either they're kaolin-based or chitin-based. These are basically just topical agents that can control major superficial bleeds. So think like a scalp bleed that's exsanguinating there. You can use this to help temporize, again, until they can get their definitive surgical control. Some other agents here, things such as like the XStat, which is used primarily in military, but now again, making it down to EMS, and that's basically an injectable form of these mini cellulose sponges that you can inject into abdominal bleeding, into basically a cavitary bleed, and it can help form essentially similar to a tampon. Essentially, it helps expand, it helps compress, and it helps reduce bleeding there. Other things that are still in trials now is this rescue foam, which is an injectable foam, which is primarily directed for abdominal bleeds. There's a current trial called Revive trial that is seeing if this is safe and if this is useful. But so far, early data for this shows that it is actually potentially helpful in forming direct pressure into a difficult to visualize bleed, especially things like if you have a GSW to the belly or a stab wound to the belly or some concern that you're having interperitoneal bleeding, this may serve as a future agent. Most importantly, though, aside from stopping the bleed, is giving the blood. And as we see, damage control resuscitation and kind of the modern trauma resuscitation focuses on reducing crystalloid and maximizing blood. Right now, obviously, pre-hospital blood is becoming a very hot topic. As of about a month ago, there were over 230 agencies that have pre-hospital blood, and this number is increasing almost on a daily basis. The only issue is pre-hospital blood is a bit of an onerous process to build. It's a very costly process to build, including the cold chain storage system, and it is being questioned about, whether or not the cost is worth the benefit. So it's a rising question, but know that you will start seeing more and more blood being given sooner to the point of injury. Now, one thing that we see with blood, while pre-hospital blood might be very difficult to these very remote locations and the whole issue with cold chain storage, so getting EMS rigs outfitted to store the blood, there's now been a push to start having drone delivery of blood. So for very remote injuries, for people that are in isolated areas and there's no immediately available blood products, blood banks are starting to coordinate this to start doing zone delivery. And there's one company out of San Francisco actually called Zipline that is working to help create these drones for blood delivery. And there's actually a coalition that's called the Blood Desert Coalition that's focusing on more third world countries where there are vast territories, like 100 kilometers to the nearest trauma center where there's no blood available at all. And that's where these are starting to become particularly useful. Now, the issue with this is we all talk about, getting blood as soon as possible, reducing our crystalloid, maximizing our blood products. The only issue here now is as the demand for blood and the emphasis on giving blood is increasing, the rates of donations are actually starting to go down. Our donor pool is aging out. The average donor is now closer to the age of 60, and the kind of retention of the younger generation is going down. There's more difficult to incentivize, especially after COVID-19. There was fewer blood drives, so there weren't blood drives at universities, there weren't blood drives at sporting events. And so we've seen, while our demand is staying basically up, if not increasing, our donor pool is starting to go down. So we're starting to hit a crux here where we want to give blood in trauma, but we might not have as much as available. So there's ways that are being trying to address this. There's a blood emergency readiness corps, which became particularly useful back in this beginning of this year, when in January on New Year's Day, that event that happened in New Orleans, they actually employed the blood emergency readiness group, where they called basically the regional centers throughout Louisiana to help bring extra blood products to New Orleans to help address the MCI that was experienced there. Other ways to address this kind of demand for blood in the times of decreasing supply is the talk of walking blood banks. We know these have been readily employed in the military setting, but now there's been kind of a national creation in Norway through the Norblood, where they called basically through the civilian population a walking blood bank where they could call on people in case of MCI. And there's one example of that here now in the US, out in San Antonio, the Heroes in Arms, which is a regional whole blood program for, again, walking blood bank for civilians. So these are things that, A, are coming our way, and B, we should know about. Now, if we don't have regular blood, there is other forms of blood coming out there. There's now attempts to create in vitro blood. So these are manufactured blood through little bioreactors, which actually provide the benefit that you don't have the alloimmunization that you're going to have by giving somebody else's blood. This is just clean blood. The only problem with this right now, aside from the fact that it takes some time to actually synthesize the blood, is that about 1 unit of in vitro blood is anywhere from 8,000 to 15,000 per unit. So, your typical blood unit is about $245. This is very far off, but it might be coming sooner than we know. And then there's also talks, as you all know, about freeze-dried plasma. There's also freeze-dried platelets, theophilized platelets. You might have heard of lyophilized plasma or freeze-dried plasma, but there's also upcoming items of freeze-dried blood, so freeze-dried red blood cells. So these are all items that might be available in pre-hospital. Again, trying to emphasize that focus of getting blood products to the patient as soon as possible. The nice thing about the freeze-dried blood is that this could potentially avoid the issue with storing blood in your EMS rigs, storing blood even for your blood bank, because the unit of blood only lasts particularly around 24 days. If it's whole blood, it's only lasting about 14 days. And if it's thawed plasma, that's only about 5 days. So all different items to look out for. Now, on the topic of plasma and cryo, we've seen a number of trials here. With plasma, we classically say, order some FFP. There's actually a version that is already never thawed, never frozen. So liquid plasma. Liquid plasma is actually something that has a longer half-life and similar improvements to coagulation as freeze-dried plasma, and it lasts about 28 days rather than 5 days. You might have heard a couple trials out there, the Pamper and the Combat trials. They've showed kind of contrasting results in terms of its benefit to trauma patients, but bottom line from both these papers you can take is that for plasma, they're safe to use, and if you have particularly long transport times, so say if you're in pre-hospital helicopter, it may actually benefit the patient. As far as cryo, you might have seen a couple of trials come out here, Cryostat 1, Cryostat 2. It does show that it's feasible to give, but we haven't quite nailed down how much we should give and when we should give. So, these are all items that are things to consider when doing trauma resuscitation, but aren't proven to be, we don't have a fixed number and we don't have a fixed time when to give it. So unlike blood and whole blood, which is like, yes, give as soon as possible, these are items that we have to think, we're still trying to find out when is best to give. Other things you might have heard, PCC. The ProCryo trial was a large randomized trial that came out. Overall, it showed PCC so far in trauma right now has not proven to be super beneficial. As far as fibrinogen, we know a lot of patients come in, majority of trauma patients come in with low fibrinogen levels, and low fibrinogen levels have shown to be increased need for transfusion, increased risk of mortality. Unfortunately, this FICE trial, which is another randomized control trial where they gave fibrinogen early into their treatment, was also a relatively negative trial. So again, these are things that are available right now, but haven't proven to be our exact dosing or timing for it. So what if you're in a center that has 4 units of blood and those 4 units are already going to some other patient? You don't have any blood. What do you give? I mean, the honest answer would be there's not a lot of great options. Everything we give is going to be a temporizing agent until you can get blood to the patient. But there's few things we can do to try to at least reduce our transfusion requirements. So TXA, I'm not going to talk about TXA. Everyone knows TXA is out there. We know from a number of trials that is beneficial to trauma patients. The only thing I would say that with TXA, focus on that should be trying to give, if you're in the pre-hospital, trying to get as soon as the patient as possible. So in the pre-hospital realm, trying to give 2 grams, 1 gram in each shoulder, 1 gram in each thigh. So giving it IM 2 grams is probably the best way to get it to your patient, is what's being shown on trials. Vasopressin is the one that is a hot topic right now because it's the only randomized controlled, it's the only vasopressor in trauma that's had a randomized controlled trial, and it showed in patients undergoing massive transfusion that it not only decreased the amount of blood products used, but it had equal morbidity and mortality. It wasn't powered for mortality in this trial, so there's an upcoming trial called Cavalier that will try to see if vasopressin actually has an improvement in mortality, but it's shown that vasopressin, in lieu of having massive transfusion or as an adjunct to massive transfusion, can help reduce our blood product utility. So some other things that we have here. So you might have heard of hypertonic saline. You might have heard of people giving albumin or hydroxyethyl starch. Just know that none of these have been shown to be beneficial in trauma, and that they actually show potential for harm, in particularly hydroxyethyl starch. So if you didn't hear about it, don't worry about it, erase it from your memory, don't use it. As you all know, we've probably heard of what was the lethal triangle of trauma, and now we're moving towards the lethal diamond. The lethal diamond is mostly the addition of hypocalcemia into patients undergoing massive blood loss. So the diamond being acidosis, coagulopathy, hyperthermia, and now hypocalcemia. Why do I bring up hypocalcemia? Because calcium is now the big item that's also being included in these bundled cares for trauma resuscitation. One caveat I will say with calcium is that there's now there's not been a fixed number of what is the best amount of calcium to give for trauma patients, and there's actually shown to be harm in giving too much calcium. So majority of trauma patients do have hypocalcemia, but some are hypercalcemic, and those who are both hypo or hyper have shown to have increased mortality. And so just know with calcium, basically, you don't want to give too much. You also don't want them to be too low. Just kind of like everything, life is about balance. Now this is going to get weird. So these are all items here that are either currently undergoing trial or even just in the animal phase. But these are things that may offer a little more protection. Those things include niacin, glitazone, specifically pioglitazone, and then something called ALM, which is adenosine, lidocaine, and magnesium. It's a combination that's usually actually used in cardiac surgery, but what it's shown is that in patients that are hypotensive, it actually improves oxygen delivery and has decreased mortality. And this is one thing that we have readily available, so as more trials come out here, that's something to keep mind on of things we can do to reduce cellular injury, improve acidosis in patients, and improve morbidity and mortality here. So keep your eyes out for that. And a few other things that to talk about. So valproic acid, with this, it's actually shown to have a little bit of a cellular protective effect, and particularly with TBI. Animal models is pretty much the only evidence we have yet, so there's no active clinical trials. Other item, estrogen, surprisingly, has been shown to improve cardiovascular function and improve platelet function in trauma. But again, and in animal models, it's shown reduced mortality. No active clinical trials. So again, things to look out for down the road, but note that these aren't yet clinically proven to be allowed. Other items here, recombinant factor 7, so Novo 7. FDA approved only for hemophilia technically, but there's a couple off-label trials for hemorrhage. Just know with this that it did reduce blood product usage, but didn't affect mortality, and it's extremely costly. It's about $15,000 per dose, and because you're giving someone coagulation factor, you increase the risk of PEs and DVTs. Factor 13. So majority of trauma patients have some degree of factor 13 deficiency. Factor 13 has been shown to be inversely related to the total amount of blood product needed for patients. So factor 13 does exist, and we might start seeing this being used in our trauma protocols because this one has factor 13 is shown not to have the same effect on VTE. Lastly, in terms of non-blood, is synthetic blood, not to be confused with in vitro blood. These are just basically oxygen carriers, but also some synthetic platelets that can be given to patients possibly down the road. Again, these are all very out there, and they're still not something that's going to be routinely available, but things to keep your eye out for down the road. And then with any resuscitation, something we do have is remember a lot of our patients, increasing number of patients are on anticoagulation. Remember to reverse their anticoagulation appropriately in the setting of massive transfusion. So with all that being said, with those different agents there to keep a lookout for, you have to remember when you're transfusing, when you're resuscitating, one thing you want to do is also monitor the bleeding. And by monitoring the bleeding, you want to do goal-directed transfusions. So that'd be things like doing point-of-care tags, point-of-care INR, point-of-care labs, all things to help us give more patient-centered care with our trauma resuscitations. Because hemostasis is not a static process. It's dynamic, and it changes as you give patients products, as they continue to lose blood. So here's a AI-generated image I created of what the future could potentially be. You know, if we could have it the way we wanted it, would be surgery at the point of contact with blood delivered at the point of contact. So, you know, 0 to 2 minutes from the MVC to when they're getting their X lab. Are we there yet? No. Are we working toward that direction? Possibly. These are all just references.
All right, well, let's take a quick 1-minute stretch break, and then we've got Dr. Johnson up next.
All right, everyone stretched. All right, we'll talk about one potentially temporary hemostatic agent now, or hemostatic device for the next 20 minutes. We'll talk about REBOA. How many people work in a shop where you use REBOA? A couple still, like maybe. In the past, I know, right? So it's funny. I'm like, maybe this is like the 21st century bloodletting, right? We're gonna look back on the days of REBOA and be like, what were we doing? Which we may very well be, right? So, but I'll talk about REBOA for the next about 15 or 20 minutes. We're gonna talk a little bit about the history of it, a little bit out of the data currently, and then what I see as like the future. And I have a lot of conflicts of interest. I'm sorry. I'm the co-founder of a medical device company called Surge Critical Care, which is a critical care robotics company. I serve on the board of a couple other devices, and then I have a couple of companies, and then I do have funding from the DoD and the NIH related to REBOA and partial REBOA and critical care automation. So, but I want to start with just talking a little bit about like where we've come with trauma over the last 30, 40 years, and kind of where I think we're going, which also ties in really nicely with what we just talked about. But if we looked at just like trauma mortality since the 70s and then into the 90s and then currently, we've seen this consistent decrease in trauma deaths. But all of that comes from saving people's lives in the hospital, right? So that's shown here is that this is in-hospital mortality, which has just slowly been decreasing. And of course, so when your in-hospital mortality decreases, if your total mortality, your out-of-hospital, the percentage increases, but really it's just stayed the same. We're just not saving more lives in the pre-hospital setting. And if we're gonna make continued improvements in trauma mortality, some of it has to happen in the pre-hospital setting. We have to make a dent in people who are dying in the field. And I think we're starting to see how things that are happening in the hospital are transitioning into the pre-hospital setting. If we look back at like, this is when we look back at the proper study and we said, the time to massive transfusion during proper, and every minute delay from the time that blood was requested to when they got blood, every delay, 1 minute, led to a 5% increase in mortality, right? So that's profound. And I think that then is what has turned into us now, what is it, 230 spots across the country where we now have blood in the pre-hospital setting, where we're starting to see maybe this sign that like if we get people blood sooner, they live, right? And also, we don't have to intubate as many of them, and they don't have to have as many sort of interventions. And so it's this move towards more and more care in the pre-hospital setting. And then if we look at timing, right? And this is data from John Holcomb, the great trauma surgeon. This is back from 2016. And he started to say, okay, what does it really take to take care of a trauma patient, right? The pre-hospital phase was, on average, this is his data, about 30 to 70 minutes. I think in Salt Lake City, we think it's probably sooner. We like to pretend it is, but in reality, it's pretty close to 30 minutes. In the emergency department, 22 minutes, right? How long? We say like, let's get them upstairs as quick as possible. On average, it takes 22 minutes. In the OR, it takes 14 minutes to prep your OR time, and then you're in there mucking around trying to get hemorrhage control at some level. So this takes a long time, right? So definitive hemorrhage control, and Holcomb was saying, like, from the time of injury, it's over 100 minutes, right? I mean, that's a long time. So if we're gonna start saving people's lives, we've got to start doing things earlier. And that's the concept one of the concepts around REBOA. Is there a way to have temporary hemorrhage control that theoretically could be applied earlier in a trauma patient's care? This is just, if you don't know a lot about REBOA, but here's like the basic concept is you just take you take an endovascular balloon, pass it retrograde from the common femoral artery up into the aorta, up above to wherever you're bleeding. And if you occlude the aorta, just like you're doing a cross clamp or anything else, the patient stops bleeding below that area. Initially, when this all started, we were using the Cook Coda balloons. I don't know if anyone remembers those days, where you had to put it in over an 035 like super stiff amplats, super long wires, total pain. If I mean, you've got a 210 centimeter wire in the trauma bay. Like it didn't work that well. We now have all of these different companies that are bringing out sort of bespoke, specific catheters for REBOA. Prytime is probably was the first to market, but now we have, this is a device out of the Netherlands called Nerescu, which can inflate on its own. This is this French device out of Canada. And then this is, I have no affiliation with this company. It happens to be based out of Salt Lake City, called Emergency Scientific. So these are all catheters that can be placed without having to go over a wire. So it's much simpler to do. So if you have REBOA currently in your shop, you're probably using one of these devices, I'd assume, because I think anyone who's still using the Kokoda is, I mean, there are better devices out there, but that's the overall idea. And like all things in, really in all things in medicine, nothing is new, right? We think, we had this revolution in REBOA and endovascular means of aortic occlusion. It actually started back in the Korean War. And this is a paper from Lieutenant Colonel Carl Hughes, who was a surgeon in the Korean War, where he actually used a Fogarty balloon for aortic occlusion in a bunch of his patients he was in like kind of a MASH unit where he's operating on these patients in the belly, and he'd actually just make an incision in the aorta itself and pass a balloon proximally and occlude it. And his takeaway was that all his patients died, right? Which isn't that surprising, I guess. But the real takeaway was every single one of the patients that I did this on, their blood pressure got better. It bought me time. I should have done it sooner, but they all died because it was a last minute effort, right? So it is definitely not new. But back then, we really didn't have great technologies to do it. We were literally in the belly, making an aortotomy, making a small incision in the aorta, and then passing a balloon up. We've gotten better since then. So people, like now we can just do it all percutaneously. We can do it. You just pass a 7 French introducer sheath into the common femoral artery. Very specific, common femoral, not the superficial. And then you can just, if you have an introducer sheath, you can then really quickly pass a REBOA balloon up to wherever you need to in the aorta. And there's a lot of debate now. Should you do a cut down? Should you do it with ultrasound guidance? I think the take home when I look at the literature is, what are you really good at? And actually, what is the person who is the best at getting vascular access good at? And that's what they should be doing. And I think you can take a lot from like the ECPR world right now. If you guys are having an ECPR program or something like that, you're putting patients on ECMO. The hardest part of all of these is actually getting the access. Once you have access, this is definitely not rocket science. It is all about getting access. So it's really relatively easy to do once you have your vascular access. And then once you have vascular access, you can decide where you're actually going to place the REBOA balloon. Where do you want that balloon to be? Do you want it to be up high or do you want it to be down low? This is the first algorithm that's still used quite a bit. This is from Brenner et al. On where should you put the balloon. So if we remember our aortic anatomy, luckily it's really easy so I can remember it, but left subclavian down the celiac is zone 1 of the aorta. Celiac down to the renals is zone 2, and then renals down to the bifurcation is zone 3. We really only use 1 or 3. And this very first algorithm that Brenner came up with was saying, if a patient has a positive FAST, and then you get a chest x-ray and there's not some massive injury in the chest, right? Because theoretically it's bad if you occlude the aorta and you actually have an injury above where you occlude, that would probably be bad. Then you want to use zone 1. If they have but if they don't have a positive FAST, but there's really, really hypotensive and you think they're bleeding, then they're probably bleeding their pelvis. You get a pelvis x-ray, you have a bunch of pelvic fractures, then you'd want to be zone 3. And this is kind of the way that I think a lot of people probably still use REBOA, is either zone 1 or zone 3. We've started to think about this where it's very anatomical, right? You're really trying to understand where the injury is and then placing the balloon where your injury is. I like to think about it physiologically. And I actually have started to talk about this. We've created a couple other algorithms around this, where really you can actually think about what do you need to happen physiologically for the patient, and then based on the patient's physiology, decide what zone you want to be. So this is some data out of pigs, and because those are most of my patients are actually pigs. And this is in a model of a profound hemorrhage. So their maps are about 20. And then we either placed a zone 1 or a zone 3 REBOA. And you can see this is the blood pressure above the balloon. This is a zone 1 occlusion. This is a zone 3 occlusion. So the hemodynamic benefits, the proximal hemodynamic benefits of occlusion in zone 1 versus zone 3 are substantially different. And that makes, if you think about it, it makes sense. If you're in hemorrhagic shock, how much flow do you think you have into your legs? It's very minimal, right? Things are sort of maxillary vasoconstricted. It's not like you have most of your cardiac output going into your legs, and that's really where you're occluding, right? So you have a much bigger physiologic benefit from zone 1 versus zone 3. We went back and actually looked at the AAST aorta registry and looked at pre versus post occlusion data in the AAST registry to say how much, what was the physiologic benefit. This is zone 3, and this is the delta, the change in systolic blood pressure. And you can see in the AAST registry, you did see a much larger change in if you had a zone 1 inflation versus a zone 3 inflation. And we don't. This is registry data, so it's not great. We don't know at what point in time they decided to say this was our second blood pressure. But in general, you have a much bigger physiologic effect from a zone 1 occlusion than a zone 3 occlusion. So I think about it in terms of, what are you trying to achieve? If you have a patient who is at the who's either dead, right? They've actually arrested, or they're about to arrest, you want to give that patient some time. You need to refill that heart. You need to you probably have quite a bit of myocardial ischemia, and so you really want that proximal effect. So you might want to go zone 1 initially, even if the patient literally just had their legs run over and you know all the injuries are low, but you want to refill, you want to buy yourself some time, and then you can always move that balloon down if need be. So we've started to publish, we've published a bunch on this. We kind of put out this new, I don't know if that many people have picked it up, but think about it physiologically instead of necessarily anatomically. Because the complications and the risks of REBOA are profound. I think we all know this. The biggest one is time. We're talking about ischemia here. And so this is the big issue, right? As soon as you include the aorta, everything below it is ischemic. In general, we say 30 minutes for zone 1. We say maybe 60 minutes for zone 3. And anything you can do to limit the ischemia. I mean, this is a bridge to nowhere if you're not getting the balloon down, right? You need that balloon to either be out as quickly as possible or doing something to mitigate your ischemic complications. The big thing today, I think, is partial occlusion. We've published on this extensively out of the lab over the years. I think we were the naysayers. Early on, everyone said intermittent. If you remember, like 2015, 16, they were just like, oh, just inflate and deflate the balloon. We were chastised for saying, no, just be very precise in your deflation. And everyone's like, that's too hard. It's not going to happen. Finally, people are actually building devices to allow for better partial flow around the balloon. So I think that's sort of the big hot topic today. If you talk to Prideheimer or anyone like that, is all this partial flow. They've actually started to look at this also within the registries, and they have shown that you have lower incidence of AKI and you have lower incidence of complications from their femoral access and distal leg complications if there's a little bit of flow past the balloon. So that's one way you can mitigate like this major issue of time and ischemia. The other thing you have to think about also is all your injuries above the balloon. So if you have, let's say, a great vessel injury, you probably don't want to increase your blood pressure above the balloon, obviously. Severe lung lashes and great vessel injuries. Pulmonary contusions and traumatic brain injuries maintain these there's still questions around if someone has a traumatic brain injury, should you be using REBOA? We've studied this in pigs, and pigs are a little bit different than humans. Not that much, but they're a little bit different. But in the animal studies, when we have a large TBI, and then we have a prolonged period of hypertension from zone 1, we actually don't see a huge change in the bleed itself acutely over the first 6 hours. But there are plenty of case reports about how patients who got REBOA and had a traumatic brain injury had worse outcomes. So this is heavily debated still. I think that with care, you don't have to create a period of hypertension in a patient if they're getting REBOA. In fact, in general, we don't see really, really high proximal pressures. We do definitely know that patients who have traumatic brain injuries and are hypotensive have much worse outcomes, right? 2 minutes of hypotension with a MAP less than 65 and a severe TBI that patient is gonna have a worse outcome. So you have to balance that. How hypotensive are they? And then you have to be smart with how you're using your adjuncts and your interventions in order to not make things worse. So continued debate here. I don't know, there will always be a debate here unless REBOA goes away, and then maybe there'll no longer be a debate. So And so this is probably the big question, is like, what is the good, is there any data out there that suggests we should actually be doing this? Or is this truly, 21st century bloodletting, and like, this is the worst thing we've ever done? This is the paper that came out last year, the big randomized clinical trial. If you've heard about it, the UK REBOA trial came out in JAMA. And this is the Emergency Department Resuscitation and Endovascular balloon occlusion of the aorta in patients with exsanguinating hemorrhage. The UK REBOA trial. If you guys read it, you will know that the takeaway is REBOA kills patients. Patients who are randomized to REBOA had worse outcomes than patients who are randomized to standard of care. This was a trial, I know Jan, I know a bunch of these people very well. Very early on, 2016, they started planning this trial. It was across all of the UK. There are a number of issues with this trial, which other people have already published on and tried to do analyses to understand whether or not this data and actually their conclusions actually hold. There are the biggest issue, I think, were 3 major issues, maybe 4 major issues with the trial. Patients who are randomized to REBOA, only 40% of them actually got REBOA. And yet all of those patients ended up in the analysis. So 60% of your patients in the non-intervention arm actually didn't get the intervention, which is a little bit of a problem. The group that got REBOA had a much higher incidence of severe TBI than the patients who didn't get REBOA. It's also a little bit of an issue. The average time from injury to intervention was over 2 hours in this patient population. This was across all of UK. So some of these patients had really, really long transport times, and then some of them didn't have the intervention until they'd been in the hospital for quite a while. We're talking about an intervention that we think needs to be used as quickly as possible, not maybe 2 hours after your injury. And then the final one is, if we look at the groups who are actually doing this, that most of them were doing about 1 case a year, maybe 2 cases a year. And that's a major issue. I think about this as being, this is like if you have an ECPR program, right? And if you follow the ECPR, this is a tool that you need reps with, right? How fast are you at getting this in a patient who is about to die? And when you're only doing 1 a year, you probably just don't have the reps. I think this study was started, Jan is an amazing clinical trialist. I respect him tremendously. But we jumped into a clinical trial before we really understood what we were doing. When we now go back and you just analyze the patients who got REBOA and you try to adjust for everything, the patients who got REBOA in those post hoc analyses actually look to actually do as well, if not a little bit better. But this remains major debate. And then the rest of the data is retrospective, right? So, the Japanese have been published. The Japanese have been doing REBOA long before we did it in the United States. Their data pretty consistently says they see an improvement in outcomes. Now, you have to realize that they use it very early on, and actually a lot of the emergency medicine physicians in Japan are also interventional radiologists, and that's just kind of how the system works. So if you end up hanging out with these guys, it's amazing what they do. Like, some of their ERs are actually like angio suites, and they can immediately go embolize stuff. So you have a group that's really, really well trained at endovascular procedures versus, looking at the data coming out of the United States in general, it looks like it may be harmful. Now, there is a new EAST guideline that just came out, I think last month, 2 months ago. They say they recommend use in patients that you normally use a resuscitative thoracotomy. But other than that, they say you shouldn't be using it. Again, they're taking all of the, this is looking at everything that's out there. And I sort of agree with them in saying, we don't actually know. I don't think we have the clinical data yet. The one clinical trial we have, I think, is actually fairly flawed. And then we also, and there's been so many changes in the technologies and everything else since this came out that I think it's really hard to understand exactly what's going on. What I will say is, if you go out and talk to the people who are using it a lot, like the people who are just, shock trauma, you talk to Joe DeBose, who's used it a ton, Megan Brenner, they're like, oh yeah, we save lives this way. If you talk to people who use it once a year, they're like, it's a goat rodeo, right? So, yeah, I think that's my takeaway on the clinical evidence. But let's go back to where I started, which is, how are we gonna save lives? We're gonna save lives in the pre-hospital setting. And so that is where, if all of a sudden you have an endovascular device that's small and portable and easy to use, can we actually use it in the pre-hospital setting? Luckily, there's a group out there who is actually studying this. So if you don't know about the London HEMS group, they're a great group who's been doing probably some of the most advanced trauma care on the street that's out there currently. And so this is their first paper, which is zone 3 in patients with suspected pelvic injuries. And in this study, they've now done about 4 times as many patients, but this was published a couple of years ago. This is patients who they predict are going to die within the next few minutes from pelvic trauma. And in this group, they had, of the patients, they tried to cannulate, all of them. Of the patients they could successfully cannulate, 61% of them had survival versus in the unsuccessful cannulation, only 33% of them had survival. If you talk to this group, they will say that all of these patients would have died if they actually didn't do something about them. So these people are walking around, they think mostly because of this. Now, a couple of them that they weren't able to successfully cannulate obviously did survive. So they're not perfect at understanding who's going to die in the next 5 minutes. But in general, this is a pretty advanced trauma group who's doing this on the streets of London. And overall, even in these patients who had very long occlusion times from zone 3, so this is all zone 3 occlusion, 31% of the ones with REBOA had a leg amputation versus 50% of those that did not. So they say their complications were probably due to the pelvic fractures and their overall injuries and not because of this intervention they did. So they proved that you could do zone 3 in the street. And then they came to us and said, you know what? There's so many patients that need more than zone 3. We're seeing all of these patients with stab wounds to the abdomen. So in London, they don't have guns, but they're really good at stabbing each other, right? So a lot of stab wounds are seeing a lot of motor vehicle accidents. We need zone 1. We need zone 1 partial, right? In order to be able to intervene on more patients. So they came over and trained in the lab with us. So Robbie Lendrum and Sammy Sadak came over for a couple of weeks and trained in the lab. And we taught them how we do zone 1 partial. And it's actually relatively difficult to do because balloons, as soon as you are no longer fully occluding the aorta, it starts it's constantly changing and moving its shape. It's really hard to control. To go from no flow to just a little bit of flow is it's tough to do, right? So and that's because if you remember from your physics, your flow is related to the inverse of your radius to the 4th power. So very small changes in the radius of your balloon lead to very large changes in flow, right? So what you end up doing is you're deflating a balloon as you go from no flow to lots of flow over half to 1 ml. So it's tough to do. We have a way of doing it. We trained them on how to do it. And then they went and then we just published on their first case series of utilizing zone 1 partial on the streets of London. 11 patients were included in this trial. All of these patients were even sicker than their initial zone 3 patients. So these are all patients who were either in arrest or peri-arrest. And what they do is initially they were trying to get 8 minutes of complete occlusion and then attempt to get into partial occlusion. Now you have a group who trains every single week on this. So if you look in terms of what they were actually doing, here's an actual patient. They initially started in zone 3, then they went to zone 1, then they got to partial, but then they realized the patient was sicker, so they went back to complete, added more blood, eventually got back into partial and got the patient to the emergency department, right? So this is a group that's very adept at what they're doing out in the field. These are their median systolic, mean and diastolic pressures throughout their courses. So they were all really sick to begin with. You can see their systolics were less than 50. And you can see after full occlusion, it increased. And then they were able to maintain that even though they were able to maintain partial flow. Their takeaway from this was that most of the patients died. So that's not that surprising. All of these patients would have died otherwise. In fact, many of these patients were already dead when they got there. In fact, the 2 patients who lived were both under CPR when this was all started. But their 24-hour survival, you'll see at 24 hours, only 3 of these patients had died. So during this study, I was on the study committee. After every single patient we reviewed the case before they'd enroll another one. These patients were dying from sepsis, they were dying from traumatic brain injury, they were dying from multi-organ failure. So it's really complicated. 2 of the patients did survive, who were both in traumatic arrest when they got to them. So I think this is really compelling data. Their takeaway, if you talk to Sam, if you talk to Robbie, they will say, we waited too long, right? You have to, if in the pre-hospital setting, you have to start earlier. And they feel much better. There's one patient here who had almost 2 hours of partial occlusion. In fact, this patient had almost 2 hours of partial aortic occlusion and walked out of the hospital 2 weeks later with both his kidneys and with the spinal cord and both of his legs, right? So I think they felt like, oh, we can do this, we can push this. We're waiting too long and not, we are, and we're actually only taking these patients that are nearly dead. And then if you have a massive traumatic brain injury, you die from your traumatic brain injury, right? So this is really interesting data. They're continuing to enroll now on this partial zone 1. Real quickly, training considerations, who should be doing this? I think the joint ACS ACEP statement came out several years ago. This is only for trauma surgeons, right? Emergency medicine should not be part of it. And then they walked it back and said, you know what? If you're emergency medicine and you're critical care trained, then maybe you should do it. And I think all of this is kind of bogus, right? Like, I'm done with tribalism in medicine. Like, it's insane. Whoever is the best at getting vascular access should be doing this. So if you are the best person at getting vascular access and you use ultrasound, fantastic. If your trauma surgeon is the best at vascular access as a cut down, fantastic. That is the person who should be doing this. We just published this paper. We use REBOA for our cardiac arrest patients if we don't have ECMO that day. I trained a group of my colleagues in putting REBOAs in. We're batting 100% for REBOA placements in our cardiac arrest patients. That's even harder. These patients are all getting CPR, so it's a super difficult patient population. So, I mean, emergency medicine physicians can do this, but we need a very strong collaboration with our trauma groups, and then everyone has to be on the same page. Whoever is best in the room, that's the person who should be placing the catheter. The future directions, just so to close this out, I mean, I think partial flow and new devices around partial flow are probably where people are going. Prytime obviously has their partial flow catheter. These devices now that can inflate and deflate autonomously. This is the Rescue device. It just does full versus none, but you know, the concept of autonomous inflation and deflation, I think, you know, we may start to see if we're going to see a benefit, it's going to be with these advanced techniques. The other part is autonomous and robotic cannulation. So there are a bunch of companies now that are building these devices that can actually basically cannulate a vessel with AI. So this is a group out of MIT called Autonomous AI, and they built a device that basically it can identify vein versus artery. It can identify bifurcation. It literally is just a target. You move it around until you see the right spot. You press a button, it puts a needle and a wire in, and then from there you just dilate up. I played with this in a couple of different sort of closed door meetings with the DoD, and it's actually unbelievably slick. It's like, I mean, I like to say I'm probably better just because I've done so much vascular access in my career, but this is ridiculously good. And so I think as we see these new technologies come about, maybe we'll actually be able to start utilizing some of these techniques more often. And potentially, I think in the future, trauma care is in the pre-hospital setting. Once a patient gets to us, we're really pretty good at keeping them alive. If we're going to actually save more lives, it's going to be out in the field. So I think it's a potential intervention. It also might just be, you know, 21st century bloodletting. I realize that. I'm very open to that. In a few years, we may not do this at all. I think the clinical evidence remains lacking. There's one RCT with significant limitations. There is feasibility with pre-hospital use. Obviously, you got to have people who are well-trained in the pre-hospital setting. That's why in Europe and UK, we're seeing this happen. And I think maybe new techniques and technologies might simplify access and the concept of partial occlusion. So that's all I have.
Great, awesome, thank you.
All right. So probably the least sexy topic, but we'll go through this a little bit quickly so we can get to the panel and you guys can ask some questions. I'm Mark Kander. I'm from Lincoln Medical Center in the South Bronx in New York, and obviously you know Mike Jones already.
Other side of the Bronx.
Yes.
Just real quick show of hands, how many of you guys have a hospital-based violence intervention program? Okay, so a few folks familiar with
Interesting.
this topic.
All right, so the most broad overview, we know that, yeah, and we're coming from a place where we're in urban trauma centers. Violence is a big part of what we do. It's a huge key driver of a lot of urban trauma around the country. And just like the really cool last two talks that you heard, traditional trauma care, trauma education, a lot of trauma dollars focuses on the treatment of the injuries and not so much on causes. And we'll talk a little bit about hospital-based violence intervention programs and trauma prevention programs in general, kind of bridging that gap between emergency care, but also, trauma prevention. So I'm not going to go over trauma stats, but we know that it disproportionately impacts, the really old who fall and the young who either get shot or do dumb things, and it kills them. And still leading cause of death in younger people. But we know that a huge percentage of traumatic injuries are, in fact, preventable. So most people, especially for the younger group, right? Most of the states in America now work with the American College of Surgeons, that's the ACS, to accredit trauma centers. And part of that process for level 1 and level 2, the higher level trauma centers, is that those trauma centers must engage in injury prevention programs and really like take the lead on injury prevention programs. Now, at worst, for those of you that work in hospitals, know that this can become a checkbox. Like, yeah, we do it. We give out bike helmets to kids and we're good. Or it can be really advanced and very impactful where you actually bridge trauma care with public health strategies, health equity issues, community engagement, et cetera. And the goal is to try and shift some of the trauma program work and the trauma care from being 100% reactive to more of a proactive, systematic kind of work through patients getting injured and how to prevent that. So also, when you're a trauma center, the trauma programs collect data points, probably hundreds of thousands of data points, in some cases, thousands for a patient in a really crazy case. Every trauma patient that the trauma teams see get put into these registries, and that produces data locally, regionally, statewide, and there's national databases. Some of the research you'll see at SAEM will often be from varying, extractions of varying trauma databases. Well, it can do really cool things without a ton of work, but you can make heat maps to see where gun violence is happening. You can figure out, recidivism in trauma. And, we did this a few years ago where, looking at PEDS patients that are repeat visitors for varying reasons for, trauma visits in the ED. Where are adults in your community falling? Is it all at like one community center, or where are kids getting injured? And you can extract all of that from trauma data without tons of work, actually. Now, what we would like to see, and what some places do very successfully, is kind of integrate and partner with a bunch of different people to figure out what to do with this information. So community-based organizations, your EMS systems, especially if it's not like a hospital-based EMS system, hospital departments. Now, it may come as no surprise to people that trauma programs are still incredibly siloed. I'll mention this later, but EM may have no idea what the trauma department's doing, even though you're all taking care of the same patients. So it's a huge opportunity to partner, even within the hospital, to create like a meaningful program that can actually impact the community. And you get the added benefit of, projects, med student projects, resident projects, to academic output for the institution, showcase the good work you're doing, impact the community at the same time. It's kind of a double win. Again, this is from New York State, publicly available New York State trauma registry data. You get data about, who's impacted by firearms, by race, by sex, age, where in the state it's happening. Mike and we work down here. All the people live down here, but we still call everything from here upstate. But where we work is that dark blue spot where we account for a huge percentage of firearm violence for the entire state, actually. New York State has lots of trauma centers. This is just mostly this is just in the city. Much different than where some of you guys come from, where you're covering, entire states or huge catchment areas. And this is something I think is really interesting. So I spent like the last couple of days, and I'd encourage anyone to do this. Just look up trauma and injury prevention programs. There'll be a lot of things you've heard of. Some of your hospitals will pop up and show you things that people are doing. What department do you think publicizes all of the trauma injury prevention work, like on every website in major institutions like in America? They're all from the Department of Surgery. Very few outside of some of the really big institutions, very few of these are like advertised or housed in emergency medicine. But there's a starting point, right? You don't have to start completely from scratch. So everyone probably knows what Stop the Bleed is. It happens everywhere. It happens in elementary schools now. That started from the ACS. We're in a Vision Zero city. There's 6 Madisons of Vision Zero city, New York, Boston. Who here has been in a city or live in a place where there's rideshare scooters, either stand-up scooters or riding scooters? It's the amount of injuries that you see in cities that have scooters is like insane. And you wouldn't necessarily know that, and public health wouldn't necessarily know that unless we all report the data. And so geriatric falls, a lot of places, this is all based on your PI data. So it should impact the community that you serve. So if you're at a place with a large geriatric community and you see lots of falls, or you are in a place where kids drown a lot, or you have to work on boating safety, car seat installations, burn prevention, et cetera, et cetera. There's hundreds of like ready-made programs that already exist all over the country. Again, based out of local trauma centers, based off of the communities that they serve, kind of mining the PI data that they get. So the goal is, start small, start local, work with the other folks in your hospital, decide where you want to start and what can be impactful for the community. And I purposely left out this part about youth violence because Mike's going to go into a lot of the detail about specifically some really innovative hospital-based violence intervention and violence mitigation programs.
I'll stick there.
Oh, yeah.
Awesome. Thank you, Mark. And I think, when you look at, I happen to be an emergency physician who is an ACS reviewer for the American College of Surgeons. I think there's like 10 or 12 of us in the country. Performance improvements and, outreach is a huge part of your designation as a trauma center, but it's also, like Mark said, it really has public health benefit. We found in the Bronx when they added in scooters that we were seeing more injuries. And so we started a whole project related to micromobility devices, quantifying these devices, who owns them, what device they use, et cetera. And we should do the same thing with our violence prevention. Unfortunately, Mark and I both work in a community that is rife with violence. The Bronx is one of the most dangerous places in the country. There's the funny saying, the most dangerous thing to do in the Bronx is to mind your own business, and that is actually true. It happens everywhere to anyone all the time, and that's unfortunate. We've created a program at Jacobi called Stand Up to Violence that is a ED, actually it's our pediatric emergency department. One of my med school buddies, Noé Romo, started this program, but with mentorship from other programs around the city and around the country. So we take really across our system. New York City Health and Hospitals is the largest healthcare system in the country, 11 hospitals across all of New York. We actually have multiple trauma centers, both level 1 and level 2 centers. There are currently several programs looking at hospital-based violence intervention programs. They take a 3-pronged approach. You can see it's community mobilization, violence interruption, and then prevention as well. Our central office, the downtown folks, the what is sort of the commissioner level individual, Dr. Mitch Katz, who's the president and CEO. His office maintains a significant amount of support, both financial, administrative, quality assurance, and support, as well as legislative. We've gotten donations for these programs from senators, representatives, and the governor to expand these programs from their early states to where they are right now. So really a multifaceted approach to this issue. 4 major programs just to kind of put out there. The 3 major ones that are happening in New York. We've got the Jacoby program, which is called Stand Up to Violence. We basically focus on predominantly gunshots and stabbing victims. We look predominantly at youth under 26, and I think we've just extended it to under 30. At Lincoln, where Mark is located, a couple, it's literally a stone's throw away, but is a whole other level 1 center with a pretty active and busy trauma service and ED. Guns Down, Life Up, they focus a lot more on youth intervention and preventing violence, but also after individuals have been either victims or perpetrators of violence, working on reentry services into the communities to prevent the cycle. The idea is to inoculate against violence and to use these programs to help reduce the issue before they occur. Kings County, a very well-known program, CAVI, Kings Against Violence. And then there are programs all across the country. Harborview really has led the way in this out on the West Coast, done some really amazing work looking at some of the public health data and linking the data from their program to future interventions and outreach. And that's the gold standard. So just a little bit, Guns Down, Life Up. Really, like I said, hospital-based intervention. It's embedded in the emergency department and in the trauma center. Individuals who are victims of violence have an intervention performed both in the ED and on the trauma floors, as well as out in the clinics. They are looking as well at violence prevention, particularly with guns, and then reentry services and youth mentorship. That has been found to be one of the prime drivers of improvements in this domain. A lot of opportunities in terms of building community capacity, job readiness, and several other areas. The Jacoby program, the one I'm a little more familiar with, because the home program, like I said, was created by one of my good friends. 2014 was launched. Really, the prime driver, we use peers, similar to some of the opiate use disorder programs that you have, where you have individuals who are in recovery. We have employed on our staff, in some respects, individuals who are in recovery from being perpetrators of violence or victims of violence. One of our most effective youth counselors, he spent 25 years up in one of the upstate maximum security prisons for manslaughter, and can come to our patients and talk effectively about what he did, what it was like being in prison and having those types of things done to him, and trying to build a connection and to try to help break the cycle. There's community mediation. We have protests when there's a significant incident. We go out with posters. We go out with the aunties and the uncles and the pastors, and we say that we don't tolerate violence in our communities, and has been effective in those areas, and we provide support services for victims of violence. 59% reduction in reentry. How did we figure this out? We took 2 police precincts that are essentially identical, and we started our intervention in one of those precincts. And the policing patterns were the same, the community patterns were the same, the gang patterns were all the same, and we saw a massive reduction in that one community, which led to some funding from the state as well as from the House of Representatives. Our local community rep is Representative Ocasio-Cortez, so she's funded significantly this program. And we've seen, like I said, lower precinct level shooting rates as well. Some, not so much numbers. We're an organization, SAEM, with a little bit more numbers, but just some words to that. Some of these programs give me a way out. It's really powerful, right? I can be more than the violence I grew up in. That's another thing. Like, individuals are growing up in these communities, and there is no option, there is no opportunity, but we're providing that for them. Like I said, we have some real hard data as well in terms of what we've been seeing and doing. For those of us in the education space, there are ways to align these programs with some of our ACGME milestones, looking at systems-based practice initiatives, looking at how we can work on advocacy, professionalism, but on also building into domains such as trauma-informed care and teaching our future generations of physicians how this can be utilized out in major academic centers or even in community emergency departments where they may practice. So big picture. How do you go about doing this? First off, don't reinvent the wheel. There are programs out there. There are people out there. We're happy to connect you with some of the leaders, and there's a lot of info out there. And there's a Health Alliance for Violence Intervention that's a framework, creates a framework for replication. I encourage you, if you don't have a program, to maybe start speaking with your trauma center about how you can build that type of program. Looking at our model in the health and hospital system, we look at violence interruption, violence prevention, and community mobilization. We are tracking outcomes in all of these domains. We're providing infrastructure and supports to help and to assist in these areas. The outcomes, both clinical and non-clinical, you can see that we are making measured data to look at whether this is actually effective. Our Jacobi program, as an example, those who were seen by the SUV team were 2.3 times more likely to attend their follow-ups. That's a good thing, right? If we can get our patients to follow up. And they're actually 59% less likely to come back re-injured from a violent trauma standpoint. So potentially a good, difficult to measure outcome, but it's still seemingly positive. I think the final takeaway, we should look at violence not from the aftermath, from the fact of, this person is in our recess bay and dead and dying. We should look at it as potentially a preventable illness that we can stop. That's, I think, one of the real key aspects. And treating the root cause, not just the wounds, is one of the things that these types of programs can do. Just some references, and I'm going to stop there. Thank you. All right, hopefully I caught us up a little bit on time. We have a few minutes for questions. I'm going to pass the mic off to Dr. Flintz.
Oh, awesome presentation by everybody today. Hopefully everybody got something out of it. So we'll take questions. Go ahead, sir.
Our enterprise doesn't simply have a fear of video. They are profoundly phobic over the subject. I was wondering if you had any recommendations on how to alleviate their phobia.
Sure, I can start, and then maybe Matt can help too. So I think really kind of getting at what the phobia is around, as it specifically concerns that the videotape resuscitation, would it be included in a lawsuit or something like that. I think really it sounds like that's the concern. I think really pointing out that there's been lots of survey data around video review over the past several decades, and there are no identified cases of that being included. In our experience, we haven't had any issues with any of that data being requested for any further investigation or anything like that. Matt, I don't know if
Yeah, and part of the discussion with our legal team was using a date for automatic deletion of these videos as well too. So part of the reason for choosing a 30 or 45 day cutoff is the time frame, to be quite honest, for subpoenas is often beyond that. So that video is deleted not because we're removing it particularly because we don't want to submit it for an investigation, but because that's our policy. And so the legal team, kind of reviewing with our risk compliance team, made that judgment of having a hard cutoff date with the idea that, again, the vast majority of those videos would be deleted as per policy prior to the ability of anybody to process a case and then subpoena video data for that. So that's part of the reason we use that time frame.
And then I think to build off of it too, if you can argue for the pros of it, particularly in like QI indicators for better patient outcomes, that's a way to get your enterprise hopefully on board, because you can argue that like this will make us better resuscitationists and create better patient outcomes for our patients. And when you look at those numbers, it's a little bit hard for anyone to disagree with that. So then it's like, how do you build the steps then to get rid of the understandable phobia?
I would say the other way that we've gotten buy-in is using a lot of the trauma PI indicators that are required for trauma certification. We've been able to prove that that data can really be attached to a video review program. And so obviously your institution wants to be a trauma center. It brings patients to their door. So kind of linking those two things together and having some financial implications for those types of outcomes, I think is important too. So. Big ally in this? Oh yeah, big time. I mean, I think that helps. Like our institution has a really collaborative relationship between trauma surgery and emergency medicine. So that type of relationship needs to be there as well.
Sorry about that. We only have 5 more minutes because there's a turnaround for the next presentation. So if anyone has a question, just raise your hand, we'll come to you. Otherwise, Dr. Flint and I have some questions as well. I did want to first mention the difference between an SAEM workshop and an ACEP workshop is really that we have evidence-based, scientific, basis for a lot of our talks. And I think all the speakers did a fantastic job of really not just bringing up their passionate topic of interest, but giving us a lot of that evidence-based, reasoning for why we should do it. So one of the questions I have for Dr. Leon was, you mentioned a lot of we're moving towards resuscitation earlier, but there is this big concept of permissive hypotension where we should almost allow the blood pressure to stay low, because if we increase it, then you're gonna have more bleeding. So how do you reconcile those two things?
Great question. And actually, if you look at a lot of what surgery promotes as damage control resuscitation, one of the hallmarks of damage control resuscitation by surgery standpoints is including permissive hypotension. And they have 3 different papers they like to cite. One of them's a retrospective analysis that points to like reduced blood product usage and better mortality. I have not been convinced about the data for it on our own end. That being said, one of the medications I include in there, that ALM, the way that it actually works is through a similar mechanism of permissive hypotension, but it does it in a way that actually doesn't focus on on reducing the coagulopathy that permissive hypotension supposedly focuses on. The whole idea of permissive hypotension is that you're going to pop the clot, and you're not, by increasing and that's why surgery is typically so hesitant in including vasopressors in trauma, because the idea of that you're going to undo the permissive hypotension and dislodge any formed clots. I'm not convinced of the data, and I think a lot of the EM approach towards this new hemostatic resuscitation kind of stays quiet about it.
So what's the goal blood pressure for you?
Goal blood pressure would be, if it's a TBI, you do want higher goals. So you typically want systolics 100 to 110, whereas if it's a non-TBI patient, I'd say between 80 to 100 systolics. MAPS
Do you
60.
include geriatrics in that, or would you change that if you get over 65?
Well, and that's where it gets that's where it gets complicated, because
2 minutes.
our chronic hypertensive patients, like their typical MAPS, they probably a good map for them is 75 instead of 65, and that's where we don't have any great data for that yet.
How about vasopressor? You talk about vasopressor. How about other vasopressors? Do you want to?
Yeah, so for other vasopressors, I'd say there's no vasopressin is the only one that's been randomized for norepinephrine. There is a retrospective analysis that was between the U.S., France, and it was U.S. and France, and it showed that in the first 24 hours it might be safe to use, but that they might end up having higher blood product usage.
Yes, ma'am.
Yeah. Oh yeah. Here. Here, you can have a louder voice.
Okay. As a recently graduated resident coming from, a level one trauma center, one of my ending experiences was doing a simulation and, having a trauma patient and with the, very unstable trauma patient who with altered mental status most likely needs to be intubated, and our teaching is basically the, resuscitate before you intubate. And at this fake simulation hospital, they had 1 unit of blood, and, I was going insane because, I grew up in New York and I'm like, I'm used to being at this level one and I'm like, the MTV box comes and it's filled with all the things that I need, right? So, people are telling me, no, this is real, this can happen. Like you can get a patient that has systolics in the 60s and you have 1 unit of blood on hand. And in those situations, what are we don't have the synthetic blood that we were talking about earlier. What's the recommendation in terms of like pushing fluids just to see if you can bring that pressure up before you intubate this patient versus you know not taking a chance, talking about blood products.
Yeah.
Congratulations.
So we are out of time, so you get 30 seconds for your answer.
All right, 30 seconds. So I'd say a lot of what I showed is try to be bridges to blood, and really there's no good alternative to blood at the moment. And in those situations where you only have a unit or you have no units and you have to use crystalloid, you can use judicious amounts of crystalloid, but you don't want to be, I'm talking like 250 cc's at a time, maybe 500. And that's because, once you start getting more into multiple liters of crystalloid, you start diluting out the blood. You get this dilutional coagulopathy, which is on top of that traumatic induced coagulopathy. And so you can actually worsen the bleeding. And while you transiently improve their blood pressure, they're gonna bleed out faster in the end. So, small amounts of fluids, maybe give some push doses of vasopressin and calcium just to keep systolics enough to keep them perfusing everything, and then eventually get them to blood, get them to surgery.
Maybe for our next session, we'll have more data about vasoactive agents, hopefully. All right, we appreciate everybody coming. Want to keep everything on time. Thank you so much. Thank you to our speakers again for a great job.